pleasure having on board with us Dr. Sandra Ganesh. She is a senior consultant in Department of Pediatric Ophthalmology and Strabismus Services, Aravind, Coimbatore. She is one of the contributors to the AIOS Myopia Consensus Statement. What more do we need? Thank you, madam, for coming over.
Thank you, Dr. Samyukta, for the kind invitation, and I really enjoyed my stay here in Thrissur, such a beautiful place, and made a lot of new friends also. So I'm going to talk a bit of all the previous speakers before me have made my job easy, and many things have been covered, but still, I think myopia being a hot topic today, there's a lot to discuss. Every time we have a session on myopia, it's almost like a very good attendance in any conference. So, why do we need to start with this kind of myopia management? So we did a small study in Aravind, Coimbatore. This is comparing the statistics of 2019 to the statistics that we had in 2022. So you can see the yellow is the new myopia cases in 2019, and the red ones is the new myopia in 2022 across all months of the year. And what we saw was what we had been observing in the clinic, that every single month the number of new myopic diagnoses had really increased. This was just after the pandemic. So definitely we should not be myopic on myopia management. As has already been said about the prevalence, the myopia prediction for India also is around 50% in 2050. So that's why we feel that we do need a dedicated time or space. Like if you have a clinic, if you're running whether any type of practice, you can set aside certain days for myopia management so that we can give the proper, the focus that these need. Or if possible, in our place we have open a myopia clinic as well. So that it's just so that there is more focus to this disease. We have been treating myopia for many years now, ever since I was joined as a postgraduate or a fellow. But what has changed is the way we look and the way we want to treat myopia. So now is definitely the times to start, because our evaluation and management has completely changed over the past 3 or 4 years. Every diopter matters, as has already been said. There is a lot of increase in myopic degenerations with each diopter of increase in myopia. Patients think that it is not important because they can do refractive surgery in the end. But what we need to make them understand is that doing refractive surgery on a -8 eyeball is not the same as doing refractive surgery on a -1 or a -2 eyeball. All the complications of progressive myopia, as my previous speaker has said, will remain the same. Even intraoperatively, immediately we have seen cases where high myopic patients have got retinal detachments a month or two after doing a refractive procedure. So these would be the key steps. Updating knowledge. Updating knowledge, we need to be abreast because there are a lot of updates which keep happening every 3 or 4 months. There is new guidelines. So from where do we update knowledge? Based from there are a lot of publications coming in, evidence-based websites and meetings. Survey your patient base, staff training, workflow process, and then study your results. So this would be the key steps to any myopia practice. Updating knowledge, as I already said, we need to consider each child as potentially myopic because the incidence is going to be 1 in 2. Survey your patient base. As I already said, once you survey your current demographics, around 10 to 15% would be a new myope in any pediatric practice, and identify the pre-myopes. As my previous speaker already said, age related guidelines, any refractive stage in like a 6-year-old, it is within plus minus 0.5, 0.75, it is okay. Then if it is like within more than that, you would think that as a pre-myope. And also when you add the risk factors, which include family history, visual environment, spending a lot of time on ear work, and binocular vision anomalies, which I will be detailing about. So then you consider that as a pre-myope. Pre-myope, why? Because it can be preventive. All the environmental factors that we talk about, once the myopia has already started, it doesn't really play a big role. But it can play a huge role in pre-myope. And staff training, you need to teach because they are going to be dealing with the patients as soon as refractionist. All of the whole department should speak the same language. If each give different information, the patient is going to get confused in the beginning because patient asks questions to everyone, not only the ophthalmologist. So they will ask the refractionist, optometrist, front office staff, everybody they will ask. So everybody needs to speak the same language. So this is the workflow pattern that we are following in the myopia clinic. where we do a thorough risk assessment followed by your clinical evaluation and then a customized treatment plan. It's not a one-size-fits-all. We need to spend a lot of time with the parents, family and the child to understand what will be the best course for that family. So the pediatric refraction, we have given the guidelines to the refractionists so that in the EMR they directly flag us to enter the myopia clinic, because otherwise we tend to miss out a lot of cases even if they are not willing for any glasses or atropine, but still we can do the behavior modification. And also to know the statistics, it's better that you give the guidelines and count all the patients. So power range that we currently follow is we taking up to -8, but we do disregard certain cases which we think are already very high progressive, but most of the guidelines say around like -4 to -6 for giving the glasses. And risk assessment form is filled by parents. Then we do the workup, which includes binocular vision assessment, biometry, then seen by the consultant, cycloplegic refraction, and then we decide on the strategy. Similarly, for review patient, we'll do the refraction, biometry, and we do the progression chart filling, and then seen by the consultant, and again deciding on the strategy. So risk assessment, evaluation followed by customized treatment. Genetics already has been talked about. So the key points in history will definitely include the age at onset. I think this is one of the most key things, because if you start at around 6 or start at around 12, it's not the same. Because a myopic child who is going to get myopia at around the 6, you are looking 10 years of progression. So the like all the modifications have to be started really early. With parental myopia, again adds on to the risk, near work, outdoor time, prior progression and prior treatment. So this is the bilingual form that we are using. It is filled by the parents when they are waiting in the clinic, so that that reduces our chair time. If we are going to ask all the questions, then it's going to take more time. Then we do like a rough risk stratification. This again is filled by the front office staff, so that consultant gets a rough idea as soon as they come in, whether it's a high, moderate or a low risk. Identification of the true axial myope, because most of the interventions, whether it's low-dose atropine or the control glasses, definitely targets only the true axial myopes. We definitely should not include many cases, which I will just tell you. Whom to treat? Age 6 to 14, simple myopia, stable cylinder. If there is a steep K or a progression in K, definitely need a topography. And insufficient evidence for pathologic or syndromic myopia, we are not treating at all. Myopia with glaucoma, even myopia with prematurity, because the etiology is completely different there. Simple myopic astigmatism, just astigmatism also we are not including for treatment. Maybe you can include that as a pre-myope and just give counseling. And compound myopic astigmatism, cylinder is much more than sphere, even that may not respond to conventional treatment. So this is the binocular vision test we need to do. The most important thing is a cover test. Pick out the isophorias, ACORA, NPA, NPC, because any of these, and MEM value, because over accommodation with isophoria, you need a bifocal ad. So axial length, without documenting axial length, it is impossible to do myopia management. Every time they come, this is the most important metric that you need to do. There are a lot of publications which say now that axial length to keratometry ratio, that is also very important compared to axial length alone. So if it is possible, you can document both the axial length and the keratometry. The clear study says around 0.16 millimeter per year as a cutoff, and this cutoff also varies according to age. So in less than 10 age group, we have a different cutoff for progression. More than 10 age group, we have a slightly relaxed cutoff for progression. The fastest axial length growth actually happens before the onset of myopia. So if we have, but sadly in our practice, it is not, we are not taking for every patient. So we cannot pick based on that. So there are axial length growth charts available, just like how you get a height and weight chart. You can actually plot these kind of charts to see how the patient is progressing. So what can you use for axial length? Non-contact biometry is most accurate way of measuring. We can either use your ILMaster 700 or LensStar myopia, both of which we are having in our setup, and that will be because they are so accurate, they can pick out even very small differences in the axial length, and it gives an average of 5 readings, so it's going to be very accurate. And with the Lenstar myopia machine, these are the kind of graphs that we get. So there is software inside based upon already pre-filled data, which gives a approximate projection of what we could expect over the next 10 years. It is not 100% accurate, but it is very useful to explain to parents. When we show the graph, all of them start listening very intently, because it's quite scary to say like 0.5 at the age of 6, looking at -7 at the age of 16. So it really has an impact. And so treatment strategies already has been detailed. So behavior, see, the kind of classrooms that we had before in India was much suited for myopia control. Right now we are having rooms which are completely air conditioned, no window, nothing, and no sunlight. But in the Western and even in Singapore, now they are making classrooms with glass walls so that the sunlight will come inside. And so we need to definitely communicate to the education authorities and the school that they should not cut all the recess periods and put them into class. The problem is, even if the parents understand, the school timings for most children is like 8 to 6. And with all the tuitions, there's absolutely no time to spend outdoor. That is the sad part. Glass and frames. Finally, it is very important to look at the glass and the frames, because if they are ill-fitting, then it is not going to help in myopia control at all. So this is the guideline that we are currently following, like less than 9 years, 0.5 per year diopter or 0.3 millimeter per year, and over 9 years, 0.3 diopter per year or axial length 0.15 millimeter per year. So this is how we are grading it right now. And this is the progression chart where our optometrist, she also fills in the previous axial length, the today's axial length, and we see the difference, and we calculate the progression rate per month, because all are not coming at regular intervals. So if we keep on seeing the number, we know the progression rate per month if we calculate whether it is normal or abnormal. And then if we add some intervention, like quite a few of our patients are on combined treatment, like low-dose atropine plus some other treatment. So then we know exactly where we have introduced atropine and how it is progressing. Peripheral hyperopia, if you are documenting peripheral hyperopia, relative hyperopia patients may respond well to the control glass designs, whereas if you have relative myopia, then low-dose atropine may be a option. That is why. And lag of memory, so you need to give a near. So these are the most important things that you need to understand when you are prescribing a control glass. So analyzing our results, we opened the myopia clinic in Aravind Hospital last June. Before that, as you can see, we had started dispensing some glasses, but we didn't get any entry on any patient data, nothing was coming. That's why we put the clinic. It's even though it is, you may have a physical clinic, or at least you can have an EMR, that there is something as myopia, so that all the patients go inside that. And that way you can get a like approximate number. Like last May, we 1,000 patients into myopia clinic in just 1 month. So that is the incidence that we are looking at right now. It is quite a significant percentage of our OPD. So what we saw is, even currently, more than like 65% of the patients are opting for the single vision glasses. Around 12% are going for myopia control glasses. I am not a taker for first line atropine because of compliance issue. Many patients stop in between, and then you don't understand whether it's a rebound or whether it is they are not responders, or compliance is a key challenge, especially because our OP is very busy. Even though we explain, they don't follow. And glass means anyway they are wearing it, so the compliance issue really comes down. And 18% didn't have a change of glasses. And when we did a study among the parents who are patients who are using single vision glasses, we saw that around 67% needed a change at 6 months. So is single vision glasses good or bad? We generally we go on the affordability, but for very low myope, like 0.5 or 1 diopter myopia, not wearing glasses is better than wearing a single vision glasses, because the relative peripheral hyperopia is made worse by wearing a single vision glass, because the focus is going behind your retina. So the single vision glass may in fact contribute to progression of myopia in a patient who is having relative peripheral hyperopia. That is why there is so much of progression with single vision glasses. Though currently the control glasses are not affordable for a majority of population. So we need to talk to the stakeholders there and try to reduce the price. But the design of those glasses, they really bring down the percentage of progression is what we have seen with our experience. Even low-dose atropine is a good option provided you can ensure compliance. Once you start, minimum of 2 years the patient has to use it, minimum of 2 years. So on comparison between the DIMS and the Hall lenses, we had given around had around 80 patients of DIMS with 6 months, minimum of 6 months follow-up. Of that, you can see that the actual length progression per month that comes to around 0.1 per year on an average with the DIMS. And glass has been replaced in 11 patients in 6 months. And that is compare the percentage with the single vision glasses. Single vision glasses is way more than this. And the Hall lenses seem to be doing even better, but the number is very less. It is not a comparable number. 30 patients with 6 months follow-up, you can see that 2 of them have replaced the glasses, and you can see the very good axial length stability there, like 0.002 per month. This is what we can measure with the non-contact biometry. So follow-up, if there is troubleshooting, how do you need, once you prescribe DIMS or a Hall lens, you need to see within a week if there is adaptation issue. So earlier we were calling every patient, but now we tell them that if there are issues, they can come in, because otherwise it's difficult for them to take a leave for that. Else we see every 6 months. And if there is significant progression, in axial length we can pick up prior to seeing in a power progression. So if we find a significant progression, I add low-dose atropine as a second line. So once you add low-dose atropine along with the control glasses, the percentage, the control comes around 80%, whereas with the glasses it's around 60 to 70%. So you get additional control there, but you need to ensure compliance. Low-dose atropine, initially you see after 2 weeks to look for any possible side effects, and every 4 months thereafter. And when to stop is, you are looking at least a year of axial length stability, not power stability, axial length stability. So red light therapy is still very nascent stages, and the thing is, it is a laser. So we need to really be sure that we don't know about the long-term side effects of this therapy. There has not been enough studies on this, but there may be some in a couple of years, it may be a good approach. So collaborative approach to myopia control is definitely essential. And the most important is not a buy and buy type of business model. We need to get the family on the same page, achieve patient compliance with whatever intervention that you are suggesting. Whatever intervention it is, environmental and behavior modifications are the most important. Without that, the entire treatment falls flat. Awareness creation and knowledge, like a lot of meetings we keep talking about myopia control right now. So I would say that this is the need of the hour for the future of our youngest patients. Thank you.
Thank you very much, madam, for the elaborative session. Purpose served. Thank you very much.